Good afternoon, everybody, and welcome to Grand Rounds. My name's Tom Ford, and I'm the chair and organiser of Grand Rounds. We were in the Gannicke Lecture Theatre last week for Black History Month, which was really nice to see people in person and particularly to be able to chat to the students before and afterwards as they gave their really fantastic talks about their experiences as Black students here with us in Tayside. But there are advantages to doing this over Zoom, and that is that it's very flexible and allows more people to attend from wherever they are. And our speaker today is attending whilst her neighbours are trying to seemingly blow down the garden and blow up the walls outside. But I've reassured Fiona that we can't hear any of that going on, and the magic of Zoom keeps everything crystal clear. So wherever you're joining from, whether it's in your office or you're at home, welcome to Grand Rounds. And we try to keep the programme as varied as we can. And it's always nice to hear from new people who've never spoken at Grand Rounds before, and particularly our doctors in training. And that's Fiona, who has contacted me earlier in the year to ask if she could have a slot to talk about the work she's been doing with others in the anaesthesia and acute pain services, talking about analgesia, pain relief for chest wall trauma. This is interesting to me as a chest physician because we do see a fair amount of chest wall trauma. We cause the trauma ourselves sometimes with chest drains, and we do struggle with analgesia of the chest wall. It's not straightforward, and a lot of our patients are older, and opiates, as we all understand, have their complications, and particularly in that age group. So this is really interesting to me. I think it'll be really fascinating to find out what the pathway is and how to access it. And we may even persuade the team to come back and give us some updates as we go forward. So usual Zoom rules apply. You can leave your camera on or off, it's up to you, but please do mute during the process. If you have any questions, please put them in the chat, and then we'll have an opportunity at the end to ask questions in real life if you'd like. Fiona, thanks very much for joining. I'll leave you to introduce the rest of the team as you go along, and thanks very much for the talk.
Thank you very much, Tom. Hi, everyone. I'm Fiona Watson. I'm currently in my last year of training in NHS Tayside in the anaesthesia department. I have with me today Anna Johnston, who's one of our core trainees. We've both done ACCS, so you might recognise our faces. We also have a foundation doctor from general surgery who's kindly going to present some results, which is added to the impact of our pathway, and that's Jan, so I will introduce them individually. I'd like to also say thanks to Alan Sterling, who's our specialist nurse in acute pain services, for supporting us with the project and maintaining enthusiasm for it. And Dr. Callum Grant, who's also been supervising the project and carries out acute pain rounds across the surgical floor. We also have our major trauma advanced nurse practitioners who have also been heavily involved with this project and reminding people that it exists. And Vicky Flynn was particularly helpful with data collection and editing the pathway as we went along. So thank you again, and we'll just start with a little bit of an introduction. It's been a pathway that's been created over the last 2 years, and we had to have robust data to take this forward and to show that we could potentially improve outcomes for our trauma patients, but also our frail elderly patients who unfortunately fracture ribs after falling from standing height. So we carried out a review of the current management and outcomes for these patients using our Scottish Trauma Audit Group data, which was kindly shared by the STAG nurses. And this was collected over a couple of years. It was a retrospective data collection, and Anna is kindly going to talk to us about what we found. Anna, are you able to take over?
Yes. I don't think I can move the slides off. Oh, perfect. Hi, yes, and my name's Anna Johnson. I'm one of the anaesthetic trainees. So we did data collection from March 2022 to March 2023 and identified a total of 176 patients with blunt chest wall trauma that had been admitted into 9 wells. Now, of those 176, 35 of them received a regional technique for pain relief, which is one of the things that we've been particularly looking at as part of the acute pain and anaesthetic services. But looking at the whole demographic in general, the average age was about 66, so definitely catching those older people. And the patients that did receive regional anaesthesia had an higher injury severity score, as well as a higher battle score, which is a severity scoring system that we'll discuss a wee bit further later on. We then broke it down and had a wee look into those patients that were over 65. Again, less of them had regional techniques, only 17 in total. But the average age was about the same. But those patients that we did get regional techniques on board had a higher severity score and higher battle score on average. So we were providing analgesia via regional technique for patients that had more severe injuries. And total, the length of stay for over 65s was averaging about 25 days. So these patients, particularly in the elderly population, are having significant hospital stays. So it's quite one of the things we find. Move on to the next slide, if that's okay. So we also looked at how quickly we were managing to get regional anaesthesia on board for these patients, as it's better outcomes if it's done earlier. And the median time to regional anaesthesia was about 1.4 days. It says 1 there, it was 1.4, so about 1.5 days before regional anaesthesia was provided. And ESP, or retrospinal plane catheters, were the most common type, but patients could also have epidurals, paravertebral and serratus anterior, which is different techniques that can be used to cover the chest wall. What was quite stark, and one of the things that led to us creating the protocol, is that these patients were admitted under 9 different hospital specialties. So quite a varied teams looking after them, which is why we wanted to streamline the management for these patients. So yeah, that's the variety of patients. So the emergency department, ENT, general surgery, major trauma, medicine, neurology, neurosurgery, and trauma and orthopedics. So a big range of teams.
Thank you very much, Anna. So hopefully this just shows you that we need to have a consistent care pathway for our trauma patients and frail patients that's patient-centred. And Jan's going to introduce a little survey that she completed. And this was to gauge what our current knowledge and understanding is of the management of blunt chest wall trauma. And this just made it even more important for us to implement this pathway. Jan, are you happy to speak?
Yeah. So yeah, I'm Jen. I'm one of the F2s in Tayside. And on my general surgery rotation earlier this year, I did a survey in the general surgery department to evaluate clinicians' confidence with regards to the management of patients with blunt chest trauma and rib fractures. So there were a total of 42 respondents, with a majority of them being foundation level doctors. Clinicians often cared for a patient with rib fractures rather infrequently. Next slide, please. With the average being on a monthly basis. And the general confidence level of managing the analgesic requirements of such patients is 3 out of 5, so not too confident. Next slide, please. 79% of the clinicians do not use any evidence-based guidelines to guide their assessment, management, and escalation of care of these patients, with only 2 respondents utilizing the battle score to further risk stratify these patients. So the analgesic prescription practices were evaluated via a short question stem depicting a fit and well 40-year-old male with no past medical history, with 4 rib fractures on his left chest, no complications from the rib fractures. He was hemodynamically stable, a NUS of 0, but in a lot of pain. It showed differing analgesic prescription practices, with only 1/3 prescribing only simple analgesia such as paracetamol and ibuprofen, underestimating the extent of pain rib fractures can cause. Furthermore, only 1 respondent remembered any adjuvants like laxatives. Clinicians were also able to appropriately identify signs and symptoms of a deteriorating patient, which would prompt them towards escalation to a senior, the pain team, or anesthetics. The most common signs that they have listed are hemodynamic instability, respiratory failure, increase in pain, signs of a frail chest, signs of pneumothorax, and infection. In conclusion, 88% of clinicians would find a chest trauma tool helpful to guide their assessment and management of a patient with chest trauma.
Thank you very much, Jen. So this prompted us to definitely go forward and to revise and almost create a new analgesia pathway for all our blunt chest wall trauma patients in Tayside. We didn't want to reinvent the wheel. This management of blunt chest wall patients, it happens across the country. I visited Nottingham and I visited Glasgow as part of a major trauma interest, and I took ideas from their pathways. Anna Johnson also helped to start up the blunt chest wall injury pathway in Fife, in Kirkcaldy, and we also used their ideas as well. So the main thing is to try and apply a risk stratification score on admission. And I think that we like numbers. I think that using a number to guide you is helpful. It gives you a sort of yes or no answer. And it means that people are prompted to actually think about why this patient might deteriorate. So using the battle score, it looks at age, number of rib fractures, chronic lung disease, if they're on anticoagulation prior to admission, and how much oxygen they are requiring to maintain SATs above 94%. The risk stratification indicates that if they score more than 16, the risk of complications arising from rib fractures would increase from 27 to 52%, which is almost double. And this risk stratification score could predict a longer hospital stay without early intervention and early administration of the analgesics that we would expect. I think it's also important at this point to highlight that even though we calculate the score on admission, if we look at the patient from the end of the bed and think they're doing all right, I think they'll be fine on paracetamol, maybe a bit of codeine. Just remember that with rib fractures, day 3 to 5 of this particular injury is a time of increased risk. As they develop, when they are unable to breathe deeply, unable to cough, their secretions build, and by day 3 to 5, they're at higher increased risk of complications. So remember to review these patients carefully every day. So this is the pathway we've created. We hope that it would be clear and easy to follow, and also provide some contact numbers for when a patient is really sick. We can ask you at the end how you think it looks, but we hope that it shows you what to do if the score is less than 15. That's usually when there's an isolated blunt chest wall injury, and that would be to follow the next steps, which I'll show you in a minute. And then a battle score of greater than 16. But we have to remember that if they have a battle score of greater than 16, they are likely to have other causes of concern from their trauma. And that might be a flail segment, it might be a hemopneumothorax, and they're more than likely to have a chest drain inserted. So I'll let you just have a little read about that. The main point we wanted to make is that these patients should be escalated early, and it is really useful to know about these patients from day 1 of admission, and then we as anaesthetists on the on-call rota can follow these patients up. In our department, we have an acute pain board where we share patient details, and it allows us to keep track of those patients that we might need to intervene on. The most common number that we would recommend phoning is 4017, which is our junior anaesthetist on out of hours. They should be able to either direct you to the pathway or direct you to a senior colleague who will be able to assist with the patient, whether that might be for an analgesic, such as regional anaesthesia, or whether actually you need critical care for this patient. Our trauma advanced nurse practitioners are also very, very much involved in the care of these patients, and they have a lot of experience dealing with these as soon as they come through the door. So I would recommend contacting them as well if for some reason you're unable to get hold of anaesthesia, or within working hours, the trauma advanced nurse practitioners are available. The surgical acute pain services are also there, and they can help guide with appropriate analgesics, perhaps if they might deviate from the pathway. So this is the main guidance that we'd like to share with you, and that is step 2, and this will be prescribed on HEPMA. We would ideally like this for all of our blunt chest wall trauma patients, and we still have to use clinical judgment, and some patients may not tolerate opiates or may have an allergy to something. So I'll let you just have a little read of that. I think the important thing to involve early with analgesia is the adjuncts, ensuring these patients have nebulizers to help them clear secretions, making sure they don't become constipated and that they're not feeling sick, as no one particularly wants to be vomiting with rib fractures. We also have put non-steroidals there as an alternative, and I think in young patients this is definitely helpful. Ibuprofen gel can be used in any age group as long as they're not allergic, and the acute pain team also endorse menthol gel as well. So the idea is on admission you would start these analgesics and then see how things go. If their battle score is higher, then you can refer early to anaesthesia. Now, we've probably used a lot of jargon and anaesthetic terms that perhaps you're not familiar with. So what is an ESP block? So an erector spiny plane block is a fascial plane block, and that just means that we try and inject local anaesthetic between a layer of muscle and fascia. This allows spread, caudal, cranial, medial, laterally, and hopefully targets the dorsal and ventral rami of the thoracic spinal nerves. It can be performed at different levels, and we try and perform it roughly in the middle of a group of rib fractures. We use ultrasound guidance for this, and we have clear endpoints which make this a relatively safe technique. We're targeting the transverse process as the erector spinae muscle extends from your cervical spine to your lumbar spine. But what is an erector spinae plane block, and why would we choose it as an alternative to an epidural anaesthetic that's been around for decades? Well, we all know that epidural is the gold standard of analgesia for chest wall trauma patients. It provides reliable bilateral analgesia over multiple thoracoabdominal levels. However, there are side effects for epidurals, and there's also contraindications. In our major trauma patients, they may be hemodynamically unstable, they may actually be hypercoagulable or hypotensive, and we need to make sure that it's a safe procedure and it's performed appropriately. We also have to remember with an epidural that they're relatively bedbound with it. They can mobilise to a chair with support, but they're unable to walk around the ward. And they also require HDU level care. And in our centre, we understand that critical care has a lot of pressure on beds. So the erector spinae plane block, because we're not targeting nerves directly, and there are no huge vascular structures around where we are working, there's a significant reduction in the risk of serious complications when performing this technique. The only thing is that if we needed to provide it for bilateral chest wall injury, then we would need to do 2 different procedures. The coverage is a little bit more unpredictable. It's called a bolus technique, so we have to maintain that opening between the muscle layer and fascial plane in order to keep the nerves anaesthetized. It does require sort of labour-intensive work from our anaesthetic team. We have to do top-ups every 6 hours, and that is because it's a fascial plane technique. We're working to get infusion pumps, but this is going to take a while. Another benefit to the erector spinae plane block is that the patients can mobilise around the ward as long as they're carrying, the understanding that if they feel lightheaded or dizzy or anything, then they'll just have to go back to bed. It can be cared for in the ward, and both procedures can last up to 7 days as long as their site of an injection is clean and the line is working appropriately. So because this is going to be an increased workload for our anaesthetists, we wanted to let you know that that was the case. So we will require a little bit of patience. We will try and get to all these patients as best we can, but we may direct you back to the pathway and say, have you tried this first? We expect, based on the data that we collected with the STAG data, that there would be an equivalent of an additional 1.3 patients a week. However, with our increasing frail population, it's likely to be higher than this. Regional anaesthesia isn't always the end goal, and if we feel that someone is coping well, then we may consider a morphine PCA, or they may not need regional anaesthesia at all. So we can review and assess a patient potentially daily until we feel that they need this. We're also re-educating our department, and ESP blocks are now a standard of care for all our anaesthetists in training, and they must be competent in this block by the end of training. There is a discrepancy in training with our consultant body, so we still have a change in skill mix, and there may be people on over the weekend potentially that can't do this procedure. However, they will always offer an alternative, whether that is morphine PCA, epidural, if the patient is unwell enough. I'd also like to highlight that because we're a major trauma service, we're now offering rib fixation, which the orthopaedic team have taken on. Joe Littlechild is the consultant. And it's usually for patients that are struggling on a ventilator in ICU, or have a physiological reason that they might benefit from rib fixation. So if anyone would like to know more about this, there's a lot of information online, and I'm sure Joe Littlechild will be open to discussion as well. So how have we implemented this pathway? Well, it's all been approved by clinical governance. We've presented at major trauma network meetings, our departmental meetings, shared it with the surgical clinical leads. We are reminding people on acute pain rounds, if they phone 4017 for anaesthesia support, we will remind them about it. And hopefully this grand round shares it with the wider hospital, as we know that there are patients admitted across the floor. So this is where to find it. It's on the StaffNet page, pain service, clinical guidance, and it's the second one down, so you can't miss it. If anyone would like them printed and laminated, feel free to do that. It's quite useful to have it as a aid memoir on the wall. So thank you very much for listening. I hope you find that interesting, and we are happy to answer any questions you have just now, or if you'd rather email, I can provide my email as well. Thank you very much.
Thanks very much, Fiona. This is really interesting. I think it's very welcome to even just highlight this as a thing. As I say, as chest physicians, we do see people who have had trauma and do have painful chest walls. And I mean, I was talking to a colleague on the walk into work today to say it's not unusual for us to see an elderly person who's had a low-level trauma and then been sent to the respiratory ward, may or may not need a chest drain, has some pain, we give them some morphine, they get a bit confused, they start to wander. If they're attached to a drain, they trip up over the tubing, or they may slip and fall, they may have a head injury, and these things escalate from what seemingly is a fairly innocuous low-level fall into a long stay because of lots of complications. And some of that you could argue is due to our use of analgesia. So I think this is really welcome. I think also that you're offered that we can contact you, and there is some continuity of this is the list of people who've got chest wall trauma, and these are the people that, so if we call, someone knows what's going on. Is very helpful. I'm padding for time in case anyone puts their hand up or has a question in the chat, but I do have a couple of comments. I suspect this is not an evidence replete zone, that there's not a huge amount of evidence for this, and you know, I know from a chest point of view, from a respiratory medicine point of view, there's not a huge amount of evidence. One of the things that I noticed is that you have nebulized normal saline in the pathway. The evidence for nebulized normal saline is in the chest world is pretty slim. I'm being generous. With a lot of the data that is positive being in very small studies, which are not particularly well done, or their abstracts at conferences, again, not very well done. And my view is that if you're going to give some saline, give hypertonic saline, because that really, really works. Or if you're not going to, if you don't do that, don't do anything. Is there something specific about trauma that nebulized normal saline is better than just giving humidified oxygen?
So no, I don't think there's any concrete evidence. We are just going on what the majority of centres across the UK are using and feel that benefit their patients. And physiotherapy also feel that nebulizers seem to help. So yeah, it's up, I guess, dependent on the patient's chronic disease level. We might change that, but I think we just wanted to keep it as simple as possible.
Yeah. Of interest perhaps to the general audience, Professor James Chalmers of this parish has just completed the world's first study in this, comparing hypertonic saline, normal saline, Naxis, and I think maybe there's a placebo arm, to see if actually any of those make any difference at all. So we may actually, once that's all been crunched, come up with, we may be at a point where we say actually these things make no difference to any outcome. And certainly in the last meta-analysis I can find in this is 2020. It was in JAMA. It shows a very, very small positive. People feel a bit better after an hour, but makes no difference to outcome. So I think it's an interesting area. I just wondered if there was anything specific. And in that padding, there has been 2 questions on the chat and 2 people with their hands up. And we'll go with Maureen Lafferty was the first to put her hand up.
Thank you. I concur, Tom. I think this is really welcome, and your tool is very straightforward and easy to use. Well, I haven't used it yet, but it looks straightforward. My comment is, as a renal physician, I'm a wee bit concerned, or it's more about your treatment pathway is about the use of morphine for those under 65. And I just wonder if you would be prepared to put something under or CKD4/5 to use oxycodone, just to be a bit cautious with morphine with our patients. But otherwise, I think it's going to be a big help, because these patients sit in all of our wards and we find it really difficult to look after. And they can be in hospital for a long time and lose and I think from a frailty point of view, they can lose a lot of reserve in that time. So anything we can do to make care better will be great.
Lovely, absolutely. And we see a lot, I'm sure, most of the medical departments will see opiate toxicity due to not just CKD4 and 5, but AKI 2 and 3, which just makes, again, extends stays and deconditions folk, and can then lead to chest wall trauma as people stumble and fall over. Colin, an expert in acute trauma, helicopters in.
Perhaps. I was just wondering, Fiona, if you saw any benefit of this being initiated in the ED, whether starting an ESP block or something earlier in a patient's journey has any positive effect on outcome, or if you see any role for us down in the basement.
Hi, Colin. Thank you for joining us today.
No worries.
Certainly in the first 72 hours, ideally we would cite regional anaesthesia. And I think, as Maureen pointed out, if you've got chronic disease, if you've got renal failure, if there are things that will prevent morphine from being a safe option, then we would like to hear about them sooner. And if you can highlight the battle score even in ED, that would help prompt the surgical admissions floor to then contact us. Or we'd be more than happy if you contact us directly about these patients, and then we can see them as soon as they arrive on the wards. We have to make a judgment, and we may, spend 24 hours watching a patient to see if regional anaesthesia is right for them. It's not right for everyone, and some patients do very well without it. But yes, knowing earlier is better than not knowing at all.
Thanks. We, Fiona and I, communicated over email a little bit when she volunteered for this, and one of my questions was about chest drains, because that's the bit that we do, inserting chest drains, and the majority of people do well actually with local anesthesia at the time and good nursing care, but some people really struggle with chest drains, really struggle. And you can't really predict who it'll be. Sometimes it'll be a strapping rugby player who's had a pneumothorax, and other times it could be anyone. So I think something we'd like to do is engage with you for, not every single person who gets a chest drain in is going to need a review, but there are some people who it's really important to keep the chest drain inside you, but they're struggling with analgesia, and the ESP block sounds like a great idea for me. Questions in the chat. Dean says, excellent talk. I think evidence not the air yet, but were lidocaine patches considered as part of the protocol sparing systemic analgesia or interventions? That's question one. And question two, from a palliative care perspective, would an ESP block be something to consider in pathological fractures if a catheter can be placed? I'm stretching you here, Fiona.
That's okay. So first of all, lidocaine patches. So I think there's different viewpoints on that. Certainly the acute pain nurses are very experienced in using lidocaine patches. I think the latest I'd heard is that they were trying to phase them out because they weren't actually licensed here. And they're overused as well. And I think they're very much site specific. If you've got someone with significant, 3 or 4 rib fractures, it's not going to work. So we didn't include it on the pathway, because we need specialist advice for that, and you should be contacting the acute pain service to prescribe them, and speak to pharmacy as well. But also, I don't think they're effective for the battle score of greater than 16 patients that we might see. The next question was, just remind me.
About ESP blocks for
Yes.
pathological fractures.
Yes, certainly our regional anaesthesia colleagues in Tayside are very happy to speak about patients perhaps in the oncology ward with pathological fractures that will improve and relieve symptoms experienced by opiate therapy. We've done some regional anaesthesia catheters for sternal pathological fractures, and ESP would potentially be an option for those patients. So yes, we'd be happy to discuss in the future if that was required.
Thanks very much. My pharmacy colleagues would, I'm sure, remind everyone that lidocaine patches were one of the prescribing areas to try to reduce is the wrong word, rationalize and make sure we're following good practice, because they're very expensive and were very overused at certain points. And I think there was a lot of primary care activity to try to reduce lidocaine use long term, but I think acute use is a different thing. So it's useful to think about it at least, but not just use willy-nilly. So somebody has said in the chat just to that, lidocaine patches are off license. Use takes about 72 hours for any benefit, and limited evidence expenses are concerned. So thank you, whoever sent that. Anna Johnston has put her hand up. Anna.
Hi, yeah, I just wanted to highlight that although ESPs are great, they are quite labour intensive, particularly for the anaesthetic. At the moment, the way it works is that the anaesthetist, we have to top them up ourselves every 6 hours. So if there's multiple ones across the hospital, that is all us that has to top them up around the hospital. So as much as we'd like to provide regional anaesthesia.
Oh, I've seen.
Ivana's signal's gone. Yes, it is labour intensive, and if especially overnight, if we're seeing at least 3-4 patients overnight, it can take our anaesthetist away from theatre. We do try and change our times to make it easier for everyone, but we'll require some patience as we increase the service.
It reminds me of being a house officer doing all the APTTs and titrating the heparin infusions. I suspect there's no one else of that vintage that used to have to do that, but I certainly understand the resource implications. More chat from Deans. Anyone also interested in menthol being part of the protocol? Is there any evidence for the use in this setting versus neuropathy? I suspect not, but any comment, Fiona?
So you're saying that for chronic pain afterwards, you think it helps reduce neuropathic signs?
I mean, I think what he's saying is that there is some evidence for this in neuropathic pain. Is there any evidence for it in this setting, or are you just extrapolating across from a parallel evidence base?
Again, that is experience from the acute pain nurses. They recommended us to keep it in the pathway. they feel that it has some benefit.
And it's cheap and it has no discernible side effects. And I think we will all probably agree that if it leads to a reduction in opiate use, then it's a good thing. But
Yeah.
this is, we've come from nothing, and this is definitely something very helpful, and I think will reduce harm. And hopefully, it's a living document that will change as the evidence changes, and we learn more about it. So I think we have come to a conclusion, unless there's any other questions. Doesn't look like it. So thank you to Fiona and others for the talks today. Really appreciate you reaching out to want to do it, and I hope you'll come back and give us an update of what's going on in the future. And I still haven't forgotten what we might try and do with chest drains. It would be helpful. Really, really good to do something with that in the future. Next week, pharmacy and prescribing. It is World Antibiotic Awareness Week, or it's coming up to that, and we're going to have a talk from, it says, Heather Kennedy, Joe McEwen, and me, as we're going to talk about antibiotic prescribing, and my bit is penicillin allergy delabeling, a program of which we've been trying to get up off the ground for some time now, and we're just on the cusp of being able to start doing penicillin allergy delabeling as an outpatient service. So we will talk about that next week. Thanks again, everyone, for coming. I'll see you again next week, and I'll update you with the plans for next week in an email at some point. Thanks so much. Enjoy the rest of your day and your weekends.
Thank you, Tom. Bye.